This program is brought to you by the University of North Carolina's Gilling School of Global Public Health.
Hello, and welcome to the internet broadcast of the 14th Annual William T. Small Jr. Keynote Lecture from the 33rd Annual Minority Health Conference. Today's conference is presented by the Minority Student Caucus at the University of North Carolina at Chapel Hill's Gilling School of Global Public Health. My name is Andre Brown. I am a second-year doctoral student in the Health Behavior and Health Education Department at the School of Public Health. My own personal public health interests include understanding social determinants of health and how things such as physical and social environments of a neighborhood influence the health of the individuals in that neighborhood. So it gives me great pleasure to serve as today's moderator for the broadcast as we further examine these issues. Before we get into today's conversation, I'd like to provide more information about the history of the Minority Student Caucus and the Minority Health Conference. The Minority Student Caucus was founded in 1971 as a vehicle for bringing the concerns of minority students to the attention of the school's administration and for working to attract more students and faculty of color to the school. The Minority Student Caucus founded the Minority Health Conference in 1977 and has conducted it annually since then. The Minority Student Caucus also works with various organizations on other activities to attract students from underrepresented groups to pursue careers in public health and sponsors community service and professional development projects. You can learn more about the caucus and the conference by visiting studentorgs.unc.edu/MSC. This year, the caucus is excited to partner with student public health organizations at George Washington University, the University of Illinois at Chicago, the University of California at Los Angeles, Harvard University, Meharry Medical College, and our first international partner, St. George's University, located in Grenada, who have all organized their own events in conjunction with today's broadcast. These partner conferences are listed on the Minority Health Conference website. For nearly three decades, Dean William T. Small Jr. assisted, encouraged, inspired, and advocated on the behalf of thousands of students at the UNC School of Public Health. Recruited to the school by the caucus, he served as its advisor and as a key supporter of the annual Minority Health Conference. When he retired from his position as Associate Dean and Senior Advisor of Multicultural Affairs in 1999, the keynote lecture was named in his honor. This year, the theme of this year's Minority Health Conference is Translational Research, the Road from Efficacy to Equity. Earlier today, we had the pleasure of hearing our 14th Annual William T. Small Keynote Lecturer, Dr. Anna Diaz-Rue, discuss the impact of neighborhood contexts on health. Dr. Diaz-Rue is a professor of epidemiology and director of the Center for Social Epidemiology and Population Health in the School of Public Health, a research professor in the Survey Research Center in the Institute for Social Research, and the director of the Robert Wood Johnson Health and Society Scholars Program at the University of Michigan. Dr. Diaz-Rue has been an international leader in the investigation of the social determinants of health, the application of multi-level analysis in health research, and the study of neighborhood health effects. Her research areas include social epidemiology and health disparities, environmental health effects, urban health, psychosocial factors in health, and cardiovascular disease epidemiology. Recent areas of work include the social environment and gene interactions and the use of complex systems approaches in population health. In just a moment, we will view Dr. Diaz-Rue's lecture, Neighborhoods and Health Disparities, Old Evidence and New Directions. As soon as the lecture finishes, you will be able to pose questions to Dr. Diaz-Rue live in our studio. You can ask your questions via phone, email, web form, Facebook, and Twitter. The information is displayed on the screen and will reappear periodically during the broadcast. And now, we will play the videotape from the 14th Annual William T. Small Keynote Lecture by Dr. Diaz-Rue, who will respond to your questions at the end of the lecture.
Good morning. Thank you, Whitney, for that very generous introduction. It's really an honor for me to be here and giving this William T. Small Jr. lecture. This is an amazing event with incredible outreach, as I've just learned sitting here listening to the introductions. North Carolina has certainly, in the area, in particular of the social determinants of health, has really been I would say one of the ground blazers in terms of work. And I'll just mention a couple of people in the area of epidemiology in particular that I have been inspired by. John Castle, Al Tyroller, Sherman James, among many, many others. So it's really, really a pleasure for me to be here. I have many colleagues and friends here. I also was thrilled to see that Argentina, my home country, is also getting connected to this event. So, buenos días a todos en Argentina también. So let me see, where's my, oh, here it is. So today I'm going to give you an overview of work that I have been engaged in for a while that has to do with how neighborhoods and places influence health and how this is relevant to understanding health disparities, and most importantly, related to the theme of this conference for intervening to improve health and eliminate health disparities. So just a quick overview. So first I'm going to just briefly review why we're interested in neighborhoods at all. Talk briefly about some of the evidence that we have so far on how neighborhoods and places may affect health. Mention the many challenges that we face in investigating this complex topic. Outline a few perhaps thoughts that have to do with some future directions in the field. And also comment more generally on some of the implications that this may have for how we think about the kinds of evidence that we need to understand and act on health disparities, because I think there are some general themes that emerge from this work that are relevant to many other health disparities related questions, not just the impact of place and health. So as I'm sure you know, space and places are a key dimension across which health is patterned, and we've known this for a very, very long time. It's one of the key features of the distribution of health. And this is just one example, a relatively recent example from an important source of scientific information, which is the New York Times, that published a series a few years ago on the distribution of diabetes in New York City. And the darker color indicates New York City neighborhoods with higher rates of diabetes. And you can see that there's almost a 5-fold difference in the prevalence rate of diabetes across these neighborhoods. And this is a very large difference. And of course, this shows that this spatial patterning is not present only for things like violence and infectious diseases, which we're very used to thinking about as spatially patterned, but also for the prevalent chronic disease outcomes of today. And you could create maps like this for many, many other cities, and you would see very similar patterns and a consistency in the way health is patterned again and again over space in a very similar way. So what explains this patterning? Well, of course, there are a number of factors. One key factor is that we know that there's residential segregation by socioeconomic and ethnic characteristics which are predictive of health. And that, of course, contributes to this spatial patterning. But there are also place-based features that contribute and perpetuate these social differences. And these two things, we have to remember, reinforce each other. So they're part of a cycle. So residential segregation, because of differences in power, in political power, in advocacy, because of the ways in which resources get allocated over space in our society, this residential segregation reinforces differences in place-based features, and these place-based features in turn reinforce residential segregation, because those with the means and the resources will locate in areas that they perceive as better for their health. So this is really a vicious cycle, and we have to remember that these things reinforce each other, which is a theme I'll come back to towards the end. Now, analytically, to study this, we try to separate out the effect of place from the effect of the location of different kinds of people, but this is artificial, and we have to put it back together at the end, and I'll come back to this. And I would say that probably this part of the equation has not received as much attention historically because we have often been focused on individual level factors as the more individual level predictors of health. And this is, and so it's potentially one avenue of intervention that has received comparably less attention, and this is why I would like to focus on it. So why focus on places or neighborhoods? Of course, there are many contexts that people are in: work, schools. Neighborhoods are just one of them, but why might these be important together with the others? Well, first of all, because we know there's a mutually reinforcing nature of place-based and individual inequalities, as I indicated before when we started talking. These neighborhood differences are not natural. They're not, a natural phenomenon. They emerge from policies or from the absence of policies that create these differences in the distribution of resources, and they therefore are amenable to intervention. We have to remember that these features may not only cause disease or cause certain behaviors, but also serve as facilitators, interact synergistically with a range of other factors related to culture, related to education, related to many other processes. So they're part of a system, which I'll come back to. Obviously, if neighborhoods are important to health, it indicates that many policies that affect health, that affect neighborhoods, may have many and perhaps even unanticipated health consequences. So it really highlights the link between policies that people don't think of as health-related, community development, economic policy, policies that have to do with the spatial allocation of resources, and important health outcomes. And finally, changing neighborhoods may have both health and non-health benefits. So this is, in fact, we're very focused on health, but there are many other quality of life outcomes that may be related to neighborhoods aside from health. So what about the contribution of neighborhoods to disparities, in particular to race and ethnic disparities? And this is a slide that summarizes some very interesting and intriguing work that Tom Leviste and his team have been publishing recently that shows that when you look at black-white differences in hypertension, obesity, and diabetes, two very important chronic disease risk factors, across integrated communities and compare it to national data, you see that the differences between blacks and whites are much smaller in these integrated communities than in national data. So this suggests that there may be something going on, something about places that are contributing and potentially are very important contributors to race differences in health. Because if you're able to hold that constant, you don't see these big differences that we see in national data. So what may be, let's think back about how some of these place-based factors may work. And of course, there are a number of complex pathways. We have residential segregation, reinforcing inequalities in resource distribution, as I indicated before. These factors shape the distribution of neighborhood physical and social environments, and these things in turn may affect behavioral factors and stress. And you see that there are a whole bunch of little feedbacks in here, which I'll come back to in the end. And ultimately, these physical and social environment features will translate through a complex set of more proximal pathways into health, and of course, operating in the context of a range of personal characteristics which may interact with some of these more environmental factors. I wanted to highlight some of the features of work on residential environments on health. Just to point out that, well, first of all, that we're really concerned with more than the classic environmental data. And what I mean by this is that it's not as important as things like air pollution and toxic exposures in the environment are, we're thinking in the work on neighborhoods and health really emphasizes many other environmental features, other features of physical environments that have to do with community design, for example, availability of public spaces, etc., and also features of social environments, recognizing that these two things also probably reinforce each other. It also recognizes a multiplicity of ways in which environments can affect health-related processes, through behaviors, through stress, through interacting behavior, stress kinds of pathways. And this is why we see some of these factors affect many, many different kinds of health outcomes, because there are many distinct and yet interrelated pathways involved. Again, these factors must interact with individual level characteristics. So it's not just that the environment that causes everything, but the environment modulates the impact of other factors. So what kind of, very quickly, I just wanted to review for you, what kind of observational evidence do we have that neighborhoods are important to health? And I'm classifying studies into two big categories. Generation 1, as I've called it here, which was really just secondary data analysis of health data sets linked to aggregate census measures. And Generation 2, which has really moved forward in trying to really collect health data linked to specific measures of residential environments, to really try to understand what are the specific environmental features that are important. So very quickly, I'm just going to review some of the early work, which, as I indicated, was essentially secondary data analysis of geographically linked epidemiologic studies, and used census areas as proxies for neighborhoods and for the variety of features of neighborhoods that could be relevant, and characterized neighborhoods based on aggregate census characteristics, because that's what we had available initially. And it's important to note that these were used really as crude proxies for the many specific social and physical features of neighborhoods that might be relevant. So it's not that people thought that the SES composition was the driving causal factor, but rather this was a proxy for many other social and physical environmental features. And this is just an example of, one example of the kinds of studies that were published, which is work that I was involved in, using data from the ARIC study, and one of the sites actually happens to be here in North Carolina. We found that we constructed a neighborhood score of disadvantaged, and we found that neighborhoods that lived in people who lived in neighborhoods with a lower socioeconomic advantage score were much more likely to develop incident coronary heart disease over the follow-up than those who lived in more advantaged neighborhoods. And this held up even after we did statistical adjustment for a variety of individual level characteristics, which we know are related to residential sorting. And you can see that we stratified the analysis for whites and African Americans, and the reason why we did this is because there was so little overlap in the neighborhood distributions across these two groups, which is a theme that I'll come back to, and also signals how these neighborhood factors may be important contributors to race differences. Just to show you another example, this is much more recent work, just a couple of years ago, doing a very, very similar analysis, but looking at people who had a heart attack and showing that a prognosis, survival after a heart attack, was also strongly related to neighborhood disadvantage, even after controlling for a variety of factors related to disease prognosis. And there have been many, many studies of this kind that have found generally similar results. So what are some of the limitations of this work? Well, it's really difficult to conclude from this that there's necessarily a causal effect of the neighborhood, because it's hard to disentangle what's called context from composition. To what extent can we really be sure that we are properly taking into account the fact that the kinds of people who live in these neighborhoods are very different? And technically, this is residual confounding and the problem of extrapolations, which is that we may not have very many wealthy people who live in poor neighborhoods and vice versa. So we're doing some statistical kind of manipulation to try to get at that, but perhaps we're not getting it quite right. Another, perhaps more fundamental limitation is that this aggregate SCS measure is really only a crude proxy for the things that might be causal. And it's crucial to identify those things, not only to get the causal effect right, but also to determine, well, what are the specific things that we would intervene on in order to change this? And so for this reason, based on this work, there were important outstanding questions about, well, do these associations reflect causation or not? And so this generated a number of questions. Well, what is it about areas that matter? How does it matter? At what spatial scale? What do we mean by neighborhoods? How should we be defining them? With what time scales do these things operate? And finally, and most importantly, can we change them and show a health improvement? So the second generation of studies has attempted to begin to answer some of these questions. And these questions are very difficult to answer, like many of the things that we deal with in public health. And so these more recent studies have really tried to measure much more specifically some of these environmental factors. And we are, in a lot of health research, we're very sophisticated at measuring things about individuals, but we're not very sophisticated. We've become a little better, but we're not very sophisticated about measuring things about ecological settings or contexts. And there are a variety of strategies that people have begun to use, often borrowing from other disciplines like the social sciences, geography, et cetera, using surveys, using geographic information systems, using systematic social observations as different techniques. Many of these studies, and I'll show you some examples, have shown that these specific measures of area attributes that we think might be related to health are, in fact, associated with area features such as race and socioeconomic composition of areas, and have begun to look at some cross-sectional and longitudinal associations with health outcomes, specifically with the more proximal health-related factors that could be in the causal pathway. So, for example, if we think about the many features of the physical and social environment that could be related to cardiovascular disease, we can outline very specific things about areas and how they would work. And so many of these studies have tried to build evidence for some of these more proximal links in order to, as opposed to just focusing on the very distal versus the final, more distal outcome. And because this is one way to build evidence for policy and for intervention. So I'm just going to spend just a few minutes giving you a little flavor of some of this work, and I'm drawing on work that we have done, but there have been many, many other studies. It was just easy for me to pull these. First of all, it's pretty clear that area features are strongly associated with area SES, race and SES composition. So this is a map of Baltimore city and part of the county showing the location of food stores, and the darker the green and the bigger the circle, the greater the healthy food availability at the store measured using an audit. So clearly the shade of the tracks shows whether it's predominantly white, predominantly black, or mixed. And clearly, there's strong association between healthy food availability, by which minority and lower socioeconomic position neighborhoods tend to have worse healthy food availability measured through presence of supermarkets or through store audits. Similar kinds of patterns if you look at access to recreational facility, very clear relationship by which, for example, predominantly minority neighborhoods or poor neighborhoods are much less likely not to have a recreational facility. These features, these kinds of features, are cross-sectionally associated with the things that you would expect them to be associated with. So, for example, access to healthy foods as proxied by the presence of supermarkets or by survey measures created specifically to assess people's reports on what's available in terms of food in their environments. Regardless of which measure you use, you still see an association by which people who live in areas with better food access tend to have healthier diets than those who live in areas with worse food access. We also see a relationship between access to recreational facilities and the probability of being physically active. And there are also associations between features of land use, for example, things that have to do with walkability, density, or measures of mixed land use, access to proximity to destinations, and walking. And these hold up after we adjust for what we can adjust for in our studies. They're cross-sectional, and there may be some bidirectionality going on here as we'll come back to. But certainly it means that regardless of whether some neighborhoods have less access to healthy foods, partly in response to what they perceive as people's purchasing desires. Nevertheless, if you advise a person with diabetes to change their diet and they live in a neighborhood with one of these neighborhoods, it's going to be very difficult for them to follow those recommendations. And more recent work has also shown that some of these neighborhood attributes are also related to the development of incident disease. So, for example, this is work using survey data to create, using special techniques to create more reliable measures of neighborhood access to physical activity, resource, and healthy foods. And these factors are related to neighborhoods that have better physical activity and healthy food resources tend to have a lower rate of development of diabetes and also lower incident obesity over time. And if you look at changes in neighborhoods over time, and this is recent work done by one of my former students, Dina Meyer, you can see that changes in the aesthetic and the neighborhoods that experience improvements in some dimensions, aesthetic, environment, social cohesion, and safety, simultaneously their residents experience reductions in a scale of depressive symptoms. So some evidence beginning to emerge that neighborhood conditions are related to incident disease, and also changes in neighborhoods are related to changes in health. Now, the literature is not all consistent, and there have been some studies, and this is one example led by a group here at UNC, showing that, in fact, they were using some longitudinal data from the Cardia study, which is a longitudinal study of young adults, and they weren't able to find that changes in access to healthy foods as proxied by access to supermarkets was associated with an improvement in diet in this cohort. They weren't able to detect that effect. And other studies have. So the literature is a little bit mixed, and it's still emerging in terms of the longitudinal associations. This is a very large study done by Janet Curry, looking at how changes in the availability of fast food around schools was related to changes in obesity rates within the schools. And they found that schools that experienced an increase in the fast food, in the presence of a fast food restaurant within a tenth of a mile, showed increases in obesity rates. And this is a within-school comparison, so it controls for school-level factors. And another study using a very large longitudinal cohort of Black women found that among women who moved, those who moved to areas of greater residential density experienced an increase in utilitarian walking, and those who moved to areas with less residential density experienced a decrease in utilitarian walking. So some evidence that the changes in neighborhood environments seem to be related to changes in health outcomes, although it's not completely consistent, and many of these studies are still going on. Now, what are some of the difficulties that we have in these studies? Well, we're looking at an effect of the context, which in this case is the neighborhood. So we have, whatever the ideal the truly relevant spatial context is that's related to health. And notice I'm not using the word neighborhood because some spatial contexts that are important to health may not be neighborhoods in the way that people usually define them. They may be different spatial definitions of areas. But whatever the true relevant spatial context is, we only have a proxy of it, and it's probably grossly misspecified, right? We're not getting it quite right, and we're not measuring what's important about it quite right. And then we have many mediators that are linking this to health. We're really trying to detect a signal that's way back here on something that happens much further downstream. So that is quite difficult to detect signals in that context. And I think we have to remember that. We also have confounders, variables that we need to control for if we want to really be able to draw conclusions about the causal impact of these factors. So we have contexts that are misspecified, we have long and complex causal chains, and we have confounders. So in some sense, it's interesting that we are able to detect effects at all, although there's strictly speaking, in an observational study, we can never completely rule out confounding, but I'll come back to this. We also have a situation where, because things are happening longitudinally, we have situations in which variables may simultaneously be part of the causal pathway, but also be confounders. So for example, if you look at a person's trajectory of where they're living over time, where they're living early on may affect what income they get later, because it affects access to education, occupation, may affect other behaviors, and these things may later affect where they live. And so these factors are simultaneously confounders and mediators. So when we're trying to adjust and just adjust away for all the confounders, we may be adjusting away part of the effect that we're really interested in looking at. And there are techniques that we can now use to try to account for those factors better. And this is just one example, also from the Cardia study, led by Magdalena Cerda, showing that she was looking at the impact of neighborhood poverty on alcohol use, and she found that when she used a more appropriate technique to account for this time-varying mediator-confounder situation, the impact of neighborhood poverty on binge drinking and alcohol intake was actually stronger than it appeared to be when we did the naive statistical adjustment approach. So there are a number of methodologic things that people are doing to help us improve the quality of the evidence that we can get from these studies. But there are, of course, limitations, which I've talked about. The measurement issue, it's very difficult to measure things about neighborhoods. Imagine, to what extent is the presence of a supermarket a really good measure of access to healthy foods? It's only partly getting at that. So obviously, and even surveys also have many limitations. So we're working in a context where the measurement is remains quite challenging. We also often have exposures which are highly correlated, so it gets really hard to disentangle. Food access and recreational facility access may be quite correlated in many of these communities. So how do we tease them apart? It can be very difficult to do that in some of our observational studies. The issue of the long causal chains, which I indicated earlier, and the fact that we still have limited longitudinal studies that look at change in neighborhoods versus change in outcomes, although I think a lot of work is coming out in that regard. And I think we also have to remember the time scale. It may be, even in looking at change versus change, if you're looking at a behavior that has been established over a life course of exposure to these neighborhood environments, it may be unreasonable to expect that a short-term change is all of a sudden going to have a very large effect, because there's a history of how these things have developed, and that history is related to life course exposures to environments, including community and neighborhood environments. So sometimes some of these short-term change studies may not be able to detect effects because there's a whole history of habituation and correlation of environmental factors over time, which it may be very difficult to overcome in a short-term change study. So, when people talk about all the limitations of observational studies, they say, well, let's do experiments. And of course, experiments have their challenges too. These are two quotes that I found on experiments. What most experimenters take for granted before they begin their experiments is infinitely more interesting than any results to which the experiment leads, which I thought was quite interesting. And there's no result in nature without a cause. Understand the cause, and you will have no need for the experiment. I still think experiments are important, but I think these are interesting things for us to think about. And I'm just going to talk very briefly about one experiment. We have very, very few experiments in the area of neighborhoods and health. Certainly a key one, which I'm sure you're familiar with because it was published very recently, is the impact of the health evaluation of the Moving to Opportunity study, which randomized families living in poverty to receive vouchers to either move to low poverty areas, a traditional voucher, or just didn't receive anything, a control group. And this is just a descriptive table showing that these groups were very similar in baseline, the characteristics, there's balance across key variables. This shows that, in fact, the people who received the low poverty voucher did indeed end up in lower poverty neighborhoods. However, that difference narrowed over time, and this may have to do with people moving back and other kinds of factors, which are a whole very interesting issue in this study. What happened when they looked at the health impact? Well, they looked at two key outcomes, at least two that were reported in this paper. This study has looked at other kinds of outcomes, mental health outcomes, which I'm not going to comment on. I'm just going to focus on the BMI and glycated hemoglobin results, diabetes, kind of measure of risk of diabetes. And they found specifically that in the intent to treat analysis, that people who had moved to these lower poverty areas experienced a reduction, particularly in severe obesity and in levels of glycosylated hemoglobin. And so the study concluded, now these were small differences, but not trivial, because comparable to many of the treatment effects that we may see sometimes using other, more traditional treatments. And so this is the conclusions of the study. As stated in the abstract. So the opportunity to move from a neighborhood with a high level of poverty to one with a lower level of poverty was associated with modest but potentially important reductions in the prevalence of extreme obesity and diabetes. And interestingly, then the conclusion also is the mechanisms underlying these associations remain unclear but warrant further investigation. So it's very interesting that this experiment is, in a sense, calling for more observational research to understand the mechanisms. Because it's true. I mean, I think that the fact is that we need to understand the mechanisms in order to figure out what kinds of interventions we would really want to do and might really work. And perhaps we don't have enough evidence to do that yet, although I'll come back to the issue of what kind of evidence we need towards the end. So understanding the mechanisms is really important. And why? Because perhaps the treatment that was evaluated in this trial, this is a very important trial, and looking at the impact of giving people vouchers and to move is a very important question. But perhaps from the point of view of health, in terms of what kinds of policies would we want to implement to reduce health disparities, what we're most interested in is not policies that move people out of places, but policies that change the characteristics of the places in which these people live. And this doesn't really provide much evidence on that at all. And so we kind of have to go back, try to understand the mechanisms, and then see what interventions based on those mechanisms we might think might be most useful. The other issue, of course, is that this whole time lag life course thing that I was talking about earlier, these people had been living in poverty probably for, in and out of poverty most likely, but they have a life course history of exposure. And so it may not be reasonable to expect a relatively short-term change to all of a sudden change things magically, although it is remarkable that they did find some differences in obesity. And then, of course, the issue with experiments, of course, is in this particular one, it's a very, very special population that the trial was focused on. And so the implications of this for policy generally in other contexts is a question. The third big theme that I wanted to talk about, we've talked about observational studies. I talked about example of an experiment in this area. I want to return to this idea of feedbacks and dynamics, which I started with at the beginning. So really, in this area, as in health disparities research in general, we are dealing with processes that are multi-level and are dynamic. And let me tell you a little bit about this. Let me make this a little bit concrete. What do I mean by this? Well, first of all, in this very simple example, if you think, well, we have this hypothesized causal chain, certain structural features of neighborhoods affect what's available in the neighborhood, and this food availability may affect dietary behaviors. This is a question we're trying to answer because we'd like to intervene here or here, and that may affect cardiovascular disease. But we have other things going on. We have things like income, the classic confounders that we already talked about, but we may have these little bothersome yellow arrows going in the other direction, which we kind of try to ignore because we don't really know how to deal with them. So it may be that family income affects structural features of neighborhoods and also affects food availability. And perhaps, although this has to be documented empirically, people's dietary choices affect what's available in their neighborhood. And also, we have other neighborhood factors. And then we have a broader context. We have the society, and we have how food is produced and distributed in society. And some of these society-wide food production factors perhaps are much more relevant to diet than, and even to health disparities in diet, than the spatial variations. So this is really a system, right, that we're trying to understand. To give you another example, if you think about the processes that generate spatial differences in health, we've talked about these two. We're saying, well, health may be affected by features of the neighborhood. So say availability of places to be physically active may promote physical activity. People are sorted into neighborhoods based on individual attributes. People of lower income and minorities may, for a variety of reasons, may have no choice but to end up living in neighborhoods with less resources. So we focused on separating out these two things in many of our studies. But in reality, there are other things. So it may be that people are selecting neighborhoods based on certain attributes, to the extent that they can, of course. It may be that people change their behavior in response to the behavior of other people around them. So if more people are walking around in the neighborhood, then people may be more inclined, to walk. And neighborhoods change in response to the behavior of residents and the actions of residents. So the presence of more physically active residents could increase the availability could lead to advocacy and changes in the physical environments of neighborhoods. And these things we don't really look at much, at least in most of the standard work that we do, these feedbacks, these dynamics. We really focus on these two first processes only. And so we may be missing an opportunity to understand how this works and also to understand the impact of the interventions and policies on these differences. So more generally, one can say that the spatial patterning of health really emerges from the functioning of a system in which individuals interact with their environment, they interact with each other, and individuals and environments adapt and change over time. This makes a lot of sense, right? So this makes this spatial patterning problem really the output of what's called a dynamic system. What is it? What are some features, theoretically, of dynamic systems? Well, factors at multiple levels. That makes sense, right? Yeah, that's obviously going on. Heterogeneous and interdependent units. People are different. They may react differently to environments. Neighborhoods also interact. Recursive relationships and feedback loops. The idea of endogeneity that economists worry about so much. So the fact that what people do may affect the environment, and what the environment may in turn affect people. This may result in effects that are nonlinear, effects that, things that, we may intervene at a point and see an effect much later that we didn't expect. We open a supermarket, it has a big parking lot, people drive to the supermarket, increases levels of air pollution. What's the final result of this on health disparities? And unanticipated effects. So these are some characteristics of dynamic systems, and they all make sense, I think, that may be occurring to a certain extent in the patterning, spatial patterning of health in neighborhood health effects. And I would argue in many, many health disparities questions. And this dynamic feature results in what's sometimes referred to as policy resistance. And this is the quotes from a very nice paper by Sturman in the American Journal of Public Health several years ago. Policy resistance is the tendency for interventions to be defeated by the system's response to the intervention itself, or when obvious solutions fail or even worsen the situation. And all of us, I'm sure, can think of, yeah, that makes a lot of sense. That happens a lot. So if we go back to the idea of the neighborhoods and health, we know that personal resources and preference can, to a certain extent, drive where people live, of course modulated by things like institutional and personal discrimination. And that affects residential location and area composition. These factors affect the location of material, social, and advocacy resources, which may feed back into residential composition. These resources affect the location of health-enhancing resources, from healthcare to physical activity, diet-related resources, public spaces, quality of public services, etc. This may also feed back. These resources we've shown are related to health behaviors, and these health behaviors could in turn influence the resources that are there. And then we may have, stress-related processes that are related to individual and area features. And these may affect health behaviors directly because people cope with stress through behaviors, and they may modulate the effect of the environment on behavior. So if you have high levels of work stress and you go home and you live in an environment where you have fast food right around the corner, you may go and say, oh, I'm just going to get a nice calorie-dense meal, I'm going to feel much better. And, so there's a modulating effect by which the environment enhances the individual level factors. And of course, this relates to health. So how can we think about this? Are there different ways that we can study this that accounts for these dynamics, which are most likely going on? So, these processes resulting in the spatial health inequalities involve feedbacks, dependencies across people. People influence each other. Neighborhoods influence each other. What's beside my neighborhood may affect what's in my neighborhood. Affects distance in space and time. Multiple paths. This dynamic idea of dynamics also involves the idea that the same outcome, some people may get, diabetes through one pathway and others may get it through another pathway. Not everybody gets it the same way. And this idea that there are emergent patterns, of which the spatial patterning of health is one example, which are not easily reducible to independent effects. So, can we think of this differently? And I don't have the answer to this. I think it makes sense. It's a challenge to us to see how we can think about this differently, and not just think about it, because people have been talking about this for a long time, but how do we do this differently? Is there a way to do this differently? What does a systems approach look like? And this is a quote from a systems biology paper that said, a systems approach does not investigate individual genes or proteins one at a time. Rather, it investigates the behavior and relationships of all the elements in a particular biologic system. And so, kind of paraphrasing that, the systems approach to the study of health would not investigate individual risk factors or individuals one at a time. Rather, it would investigate the behavior and relationships of multiple factors and multiple elements in a particular population system while it is functioning. So, how is it different from what we often do in research, in health research? In some ways it's similar, and in some ways it's a little different. And both things are complementary, as I'll come back to. But so the systems approach would define the components of the system and compile information on them, and create a dynamic conceptual model of the system that involves really careful thinking about these feedbacks. And that also involves setting bounds, because it's not about putting everything in there. It's really about thinking about, well, what are the essential elements and what are the essential dynamics? So it involves reducing to the essential elements, just like other scientific approaches do. We have to simplify things to study them, but it's a different kind of simplification, perhaps, than the one that we do when we do a regression model. And this has to be question specific. Then we can develop a formal model, which is a simulation model, to explore how the system functions, to answer fundamental questions about the dynamics, and to obtain predictions under specific circumstances. And hopefully, this will allow us to draw conclusions regarding drivers of the patterns that we see and the plausible impact of interventions. Now, I'm just going to show you very briefly one implementation example of one of many tools that are available in systems approaches. This is an example using something called agent-based models. And just to give you a very brief overview, these are really computer simulation models, computer representations of systems in which agents interact in space and time. And these agents can be people, they can be businesses, they can be governments, they can be stores, etc., advocacy groups, whatever. These agents change or take action in response to things, in response to their own history and attributes, in response to their interaction with other agents, in response to the environment, and in response to prior experiences that they have. Sounds a lot like many of the things that we do, probably. And then one can use simulation to observe how patterns emerge from those interactions and to contrast the impact of interventions in this virtual world. So we create a virtual world where all these dynamics are programmed in, and then we try to understand the dynamics, perhaps answer fundamental questions about the dynamics, and then try to identify some plausible impact of interventions. Now you can already begin to see there are lots of assumptions that go into this as well, and this is one of the very important caveats. And these agent-based models can be of various types. They can be very abstract, or they can be highly detailed. I'm going to show you an example of a highly abstract, highly stylized approach, which is really used mostly for generating hypotheses and for enhancing our intuition about dynamics, as opposed to making a specific prediction. I think these models to make very specific predictions are really probably not, at least in my view, not the most useful utility of these models, because we're really not talking about prediction. We're really talking about understanding processes better, so that from that understanding we can identify policies or interventions. And I'm just going to show you, just to make this concrete, a simple example that applies this tool to the spatial patterning of health. And this is work led by a colleague of mine, Amy Auchincloss, who is now at Drexel University. Why did we think of applying agent-based modeling to neighborhood effects questions? And the reason why these simulation tools are appealing is because they explicitly allow for two key issues which people know are going on in neighborhoods and the ways in which neighborhood affects health. This is this bidirectional person-environment relation. You know, people may select into neighborhoods based on certain characteristics, and they may also affect what's in their neighborhoods, and this allows us to account for that to a certain extent. Interactions between agents, we can account for networks and norms, and also in the idea that physical and social environments are interrelated and affect each other, and that also things are spatially segregated in space, and these approaches, these tools are especially useful for when space is a key driving, where things are spatially patterned. So this is the example of a paper which is intended to really just explore the utility of these tools to look at income inequalities in diet and the impact of residential segregation and differential access to healthy foods. And I'm not going to go into the details of this, but just very quickly, the background is that income differences in diet are well established and may be a potential contributor to health disparities. We know that there's spatial segregation of healthy foods, but there's still questions regarding, well, does that generate health disparities? Is this a causal issue? Is this the cause or not? And so we did two exploratory questions. One was, well, in this virtual world, let's pretend that there's no differences in preferences or in price across neighborhoods. So it's not that. One argument that's often put forward to explain differences in diet by neighborhoods is that, people in these neighborhoods prefer these kinds of diet, and so what's available is what they prefer. It's not that what's available is affecting what they eat. So let's hold that constant. Let's assume away this and see whether, just by virtue of the spatial segregation of people and access to healthy foods, we would see these health disparities in diet emerge. So it's a kind of proof of principle exercise to say, yes, this could emerge even if there are no differences in preferences across neighborhoods. And then if we're able to demonstrate that, how would price and preference manipulations, which are both possible interventions, health education, for example, to manipulate preferences, or subsidies to manipulate price, how would that affect inequalities? Two examples of policies. Now, this is not intended to give a conclusion or a policy recommendation. It's just intended to help us understand how these things might work, so that then we can test them in other ways. So the model has two kinds of agents, households and stores, and households have attributes and they buy food, and where they buy food affects their diet, and stores also react to what people are doing. Are they buying? They may go out of business. They can be healthy or unhealthy food stores, etc. I don't have time to go into the details. So there are, of course, important assumptions built into the model, which, to the extent possible, one can use data to inform. And then we can compare, well, do income differences emerge under various segregation scenarios? And then what happens to these income differences when we vary price and preferences? And I don't have time to go through the results, but I'm just going to show you the examples of the kinds of things that one can get out of this. So this is just a figure showing the extent of the income disparity in diet, which is just the black box, under different segregation of stores and people. And you see that there are certain segregation scenarios in which the disparity emerges, and indeed, even when preferences and price are held constant, if there is spatial mismatch of healthy food stores and people, we see the expected disparities in diet emerge. And then in another analysis, we did a variety of experiments. So this is the baseline difference in diet in the context of segregation of people in stores. And this is what happens to that disparity when we increase preferences for healthy foods. Say we did a great health education campaign. Turns out the disparities in diet don't disappear, even when we change preferences. What happens when we manipulate price? What happens when we manipulate price and preferences? So what did we learn from this exercise? Well, we learned that segregation can create disparities in diet even in the presence of no differences in preference or price. We saw that changing preferences was not enough to revert this. So acting on, say, enhancing people's desire for healthy food without changing their environment didn't change things, under the assumptions of our model, of course. We saw that price manipulation seemed to have a bigger impact than preference manipulation. We realized that the dynamics of the stores, how stores respond, is really an important factor to consider. And so that's something where we need to do more research. Most importantly, because these are all conclusions that, of course, contingent on the assumptions that are in the model, and we realize that a lot of times we don't have enough data to justify many of those assumptions, which points to what kinds of data we need to collect. But most importantly, we thought about the processes, which we don't often do, I think. Well, I should say, maybe I feel I don't do as much as I should, because we're so focused on the traditional approach, let's isolate this effect from that one, that we've stopped thinking about the processes that are underlying the associations that we're studying. And these models really force you to think dynamically, because you have to think about the feedbacks, and well, does that make sense? And is there any data to support this, so it really forces you to think about things in a different way. And I think that's valuable whatever analytical approach we use later, whether we use these complicated simulation models or not. I'm not advocating that this is going to solve all our problems, but just thinking about it that way, I think, in terms of dynamics, makes a difference. And when you do these models, you realize that there are lots of areas where we have no clue what's going on, and we need to better understand some of these things. So it generates ideas for new data collection. I think I talked about this. There are many caveats to using these approaches, and they have to do with the fact that, as I said, you don't want to make this model include everything, because then you won't be able to learn anything from it. So keeping it simple but relevant, and this is a big challenge. What are the boundaries of what we're studying? The idea that and there's a tension between using these approaches as thought experiments versus prediction. And as I said, I lean more towards, additionally now, using them more as thought experiments. An interesting thing is that when you develop this dynamic conceptual model, you can also use that approach to have stakeholders interact, and you can share the conceptual model with people and get feedback from experts, from communities, from stakeholders. And many people who do systems research actually find that to be a very, very important output of using these approaches. Assumptions, as I indicated, are a big issue. I think public health is very good. I think a very good thing about public health is that we are grounded in data, and I think it's important not to go into this kind of virtual data-less simulation world. This is an arduous process to do this, I can tell you, and how to communicate these models, which can be complicated, is a challenge. And finally, when does it make a difference? When do we learn something new that we wouldn't have predicted from what we put into the model? And this is also a challenge in using these tools. But stepping back, the key points are, the spatial differences in health emerge from the functioning of a system. Systems can be investigated using many approaches. So it's not just about simulation modeling, but many different approaches, including experiments, including observations, can be used to explore systems. And a really important point I want to emphasize is that sometimes the methods that we use can constrain the way we think about things. And I think that's happened a little bit to us. So we're very focused on isolating independent effects, isolating this causal impact of a single change in a single variable. Sometimes that starts to change the questions that we ask. So we only ask questions about independent associations. We stop asking questions about the more dynamic processes. And I think that's a danger, and this is why having a variety of tools and methods can be very refreshing to health disparities research in general. So how do we generate knowledge that's important for action in public health and health disparities? Observation is important and will continue to be important, and there are many things that we will not be able to answer without using observation. But observation can affect, and we have known for a long time, observations can lead to experiments, and experiments can lead to new observations. I showed you the conclusions of that moving to opportunity trial, or lead to the desire for new observations. Observations can also be inputs to systems approaches that can help us put together varying sources of data and see how all that information works together. And systems can also say, oh, we need to go back and collect some other data because this we don't know about. And similarly, systems, if we identify, in our example, if we were to identify, what would happen when we did a certain intervention on price, we can say, well, maybe we need to do an experiment to verify that this is true in the real world. And the experiment can also provide input into the simulation model. So we really need to think about integrating these different ways of understanding reality. But also, in public health, we often need to take action in the absence of perfect evidence, because taking no action is action. and so I think taking action based on the best available evidence and evaluating the impact of that action is also a crucial part of this diagram. And I don't think, I'm primarily a researcher, and I feel that as researchers, I don't feel that we interface as much with people who are by action I mean, intervention policy, a broad range of actions. We can learn about the causes of things from observing and evaluating action, and action can provide information that then we can integrate into the other approaches that we do. So really thinking about this dynamic evidence action system as opposed to just we're getting the evidence and then other people are going to implement it. Thinking about how that works together and how both fields can benefit each other, I think, is key in health disparities. And so a few concluding thoughts. This importance of mutually reinforcing nature of place, space, and individual inequalities. The complementarity of different types of evidence, including evaluation of evidence, not letting the methods we are used constrain the questions that we ask. Systems thinking and its implications for conceptual models, very important. Perhaps the most important, evidence and action. And complexity should not be paralyzing. Things are complicated, but we can study them. We've been doing this for ages, and we need to think about the best ways to do this. And just to finish off, I'm going to show you just a few quotes. One is a quote from Forrester, who is a big kind of father of systems thinking in many ways. In the complex system, causes are usually found not in prior events, but in the structure and policies of the system. I think that makes a lot of sense to anybody who's interested in health disparities. So the issue is how can we better use the tools that we have to be able to articulate exactly how this works in order to create compelling evidence for action, for policymakers, and for community action. And these are two final quotes from an epidemiologist called Roel Stalones, some of you may be familiar with, who published very, very few things, but very incredibly insightful things at a time when people didn't have to have so many publications. We just had a few good ones, and that was enough. So the burden of disease on a human population is part of an environmental system, and the interrelatedness of the components of the system cannot be understood by pursuing research whose rationale is to divide and isolate the components in ever greater detail. And if we consider disease to be embedded in a complex network in which biologic, social, and physical factors all interact, then we are impelled to develop new models and adopt different analytic methods. And he said this many, many years ago, and many other people have said this as well. And so I think we're at a time when perhaps we can think about how we can combine different kinds of tools in order to really address this problem and create, think about some of the health disparities questions in new ways so that we can kind of change the vision and change perhaps the answers that we get and lead to more compelling action. And just to finish, I want to acknowledge the many, many people, not all of them are on this list, whose work and also ideas I have drawn on in this presentation, many of students, former students, colleagues, and some of the funding sources that we've had. So thank you very much, and I look forward to your comments.
Welcome back to the broadcast of the 14th Annual William T. Small Jr. Keynote Lecture from the 33rd Annual Minority Health Conference. Dr. Diaz-Rue is here in the studio to respond to your questions and comments. Please call us at 1-877-869-7811 or send us your question via email, web form, Facebook, or Twitter. Dr. Diaz-Rue, thank you so much for being here with us today.
Pleasure.
Okay, so we're going to go into our first question for you. It's actually an email question from Kathy Tosa Milligan, who's a graduate student at the University of Illinois in Chicago. Her question is, in the field of epidemiology, we are trained to disentangle and isolate the individual effects of a particular predictor so that we may design programs to target that specific predictor. Dr. Diaz-Rue offers that, in fact, in order to move from this impasse in health disparities research, that we should move towards systems modeling because it more appropriately mimics life rather than approximate it. And so her question is, as students and budding researchers, how do we shift our thinking and, more importantly, our funders' thinking away from the convention of individual level modeling to this concept of systems modeling? And how will we then design programs to accommodate this holistic systems modeling approach?
Okay, that's a very good question. So I think, we need to do both things. Mm-hmm. So we need to learn how to isolate effects mm-hmm. in order to be able to demonstrate what impact they may have. But we also need to recognize that sometimes we may not totally be understanding the true impact of that factor by abstracting it from all the other things that mm-hmm. might modify its effect or interact dynamically with it. So I think it's an issue of complementarity of approaches. So I wouldn't say that we have to abandon everything that we do. We still have to continue to do that, but we have to start thinking about putting what we learn from those studies together in ways that help us better understand how they integrate into systems, because understanding those systems may help us predict what would happen if we intervene on it in the real world. So I think both things have a place in science. Mm-hmm. It's not just one or the other. And there may be situations where isolating the effect of a factor is perfectly fine. So it's both.
Okay, thank you very much. So one of the questions that I actually have personally is that as we sort of talk about translational research, I wonder what your thoughts were on how do we engage community? Mm-hmm. And so how do we get the information about systems, about those individual and neighborhood factors to our community and partner with them in a way that's going to bring about some substantive change?
Yeah, I think that is also a very important issue. I think, well, one of the important things that we can contribute as those of us who are more on the research side is to provide evidence that can be useful to communities to advocate for a variety of different things. And so we have to provide that evidence in the most compelling way that we can. Mm-hmm. So be rigorous and intellectually honest about the evidence, and also present it in ways that are understandable to people, so that they can then use that information through a variety of different advocacy and political processes to advocate for the kinds of things that we need to reduce and eliminate health disparities.
That's good. Okay, we now have a phone call.
Okay.
Caller, if you could please give us your name and where you're from, and then your question.
Is it me? Hello?
Hi, can you hear us?
This is Anthony DeLucia.
Oh, go ahead. Go ahead with your question.
Should I be on mute?
No. Go ahead.
Okay, this is Anthony DeLucia, East Tennessee State University. I really loved the presentation. I've heard Dr. Diaz-Rue on one of the Fed bank webinars before talking about early childhood development, and it was very provoking. I have a question since one of the final slides talked about OBSSR and the Office of Behavioral Science and Social Studies Research. The connection with happiness. It seems to me that there's been sort of a paradigm shift from, looking at gross domestic product and some of these things to looking at some more achievable things with happiness. Could you comment a little bit whether agency really starts to become at the neighborhood level where people are focusing on less stressful objectives like being happy and what could be attainable through community design and income and education and things like that?
Sure. So if I understand correctly, you're asking about happiness as an outcome. Is that correct? Am I understanding?
Yes, and the gross domestic product or the happiness product of Bhutan, for example.
Mm-hmm. Yeah. So I know there's been a lot of interest in looking at factors associated with happiness. I think it's a concept that's challenging to measure because I'm sure there are many complicated ways in which people think about their happiness and conceptualizing it and measuring, and cultural differences in the way in which people think about it. So I think it's a very challenging area. And I think there may be reasons to focus on outcomes that have to do with people's perceptions of their quality of life and their general satisfaction with life. However, I think as health researchers, I think it's also important for us to focus on specific health outcomes and to be able to articulate how the context in which people live and explain and understand the extent to which the context in which people live affect health through very specific pathways that we can talk about. So it's not just about context affecting people's perceptions and satisfaction, but it's about context affecting the way in which biology works and the way in which bodies develop and the way in which disease develops in very, very concrete, specific ways. Because I think that's the strongest evidence that we can put forward for policies that intervene on these more distal determinants as ways to improve health and reduce health disparities.
Thank you.
Thank you. Okay, our next question is an email question, and it comes from Aiden Nazmi, who's an assistant professor at the Department of Food Science and Nutrition at Cal Polytechnic State University. And his question is, can you speak to some of the potential challenges related to creating policies or interventions based on data from dynamic systems approaches to research, especially addressing disparities?
Yes. Hello, Aiden. How are you? Aiden and I worked together for a little while at Michigan. So first of all, I want to be clear that I'm not advocating that policy be based on the output of systems models. I'm really thinking about systems, and many people are thinking about using systems tools as a way to help us better understand how things work, so that then based on that we can determine what interventions might be useful. So I think it's one more element of the kind of evidence that we can provide to policymakers. And of course, it would be very naive of us to think that policy is developed exclusively based on evidence. That's not the way it works, right? It's based on many different things, including the political process and advocacy and differential distribution of power and ideology. And so I think what our job as scientists is to provide the best evidence that we can, and then as citizens, we may act on it in many different ways. So the systems modeling is just one more tool, together with experimental evidence and together with observational evidence, which is also very important for policymaking.
Okay. So we have a question from Facebook, which is very exciting. And it's another question sort of related to the community-based participatory research project. It comes from TJ Ikena, who's an MPH and first-year medical student at Duke University. Okay. And the question is, how do we incorporate community-based research projects to involve the community in interventions projected towards addressing some of the various factors that affect community members' perceptions towards healthy choices regarding diet. So really thinking specifically about individual perceptions and not maybe necessarily so much the resources and things that are around there. The example that he gives is that the YMCA recently released a CBPR framework called the Community Health Living Index, which is a tool to help communities assess its support for healthy living. How do you see these tools and methods being incorporated into some of the agent-based models that you talked about, using sort of a CBPR kind of mind frame, if that makes sense?
So that's a good question. So obviously there are many, many different ways in which communities can be engaged with these topics from, at different stages throughout the whole process. And different research projects do that in different ways. So communities can be involved from the very beginning in terms of assessment of needs, assessment of what some of the most important questions might be, through the whole research process, as community-based participatory research does, and also in making use of the evidence that we provide, even if it's obtained through approaches that do not necessarily involve community-based participatory research. Communities can still benefit from that kind of evidence. In terms of the systems idea, I think one very interesting thing about systems approaches is that one can come up with a systems model, which is essentially just, and when I mean systems model here, I don't mean a complicated computer model, simulation model. I mean even just making a diagram of a conceptual model that involves some feedbacks, that involves interacting factors. And one can share that with communities and have a conversation about what the causes of hypertension in this community might be. And through that exchange, the conceptual model can be refined and improved, and then simulated or tested. So this approach to systems thinking also gives us the opportunity to interact in a different way with communities and with stakeholders in terms of developing a dynamic conceptual model that then we can build evidence for, or we can simulate using a formal model, or we can look at the results of a simulation and share that with communities and get their perspective on whether this makes sense, or how we what are some of the other things that need to be considered. So there are ways in which both things can be synergistic, I think.
I'm going to use my moderator's privilege a little bit. One of the things that I'm really interested in as a doctoral student is, what are your thoughts about how schools of public health, departments within schools of public health can train their students and really provide them with the resources and sort of knowledge and skills that they need to sort of think about these systematic approaches to health, and really deconstruct them in a way that we're actually able to look at all of the components and decide where to intervene.
Yeah. So I think, and I think this is a direction in which many schools are moving and have been moving, is that I think it's very clear that we need to train our students in ways that are interdisciplinary. So you need to be able to draw from different disciplines. So that's key. We can't have departments that are silos and don't talk to each other. We have to have schools of public health talking to social work schools, talking to, departments of economics, talking to sociology, talking to public policy, talking to medicine. And I think that's happening more and more. I think there are ways in which we can also think about incorporating training and at least some exposure of our students to systems thinking. And it doesn't have to be, fancy, very complicated computer modeling. It can just be, giving people the exposure to what systems, what dynamic systems models are about, so that later on they might be able to utilize that. And even if it's just in terms of thinking about things and not necessarily running computer simulations. So.
Absolutely. Thank you. So our next question comes from Twitter. And the question is, what are your suggestions for strengthening our evaluation of public health action to ensure that public health programming is effective at improving health outcomes?
Can you repeat that again?
Yes. The question is around evaluation of public health action, and sort of what are the things that we can do to strengthen that evaluation to ensure that public health programming is effective in doing what it's...
Well, I think we need to have more interaction and partnerships between the people who are doing programs and policies and the researchers, because I think both sides will benefit from that. I don't think we do enough of that. Clearly, I think in the area of neighborhoods and health, we can certainly learn a lot from evaluating the changes that are happening in neighborhoods all the time. Sometimes because they're the result of specific policies, and sometimes because they're just changing for a variety of reasons that have nothing to do with health. So evaluating those things in a way that we can learn from it is really important. And I think increasing partnerships between communities and between policy, people who are doing policies and interventions and researchers, so that we can evaluate things in a timely manner, because time is often a key issue, is really, it would really be important.
Okay, thank you. Our next question is an email question, and it's a current postdoc student of yours, I do believe, named Malavika.
Malavika, yes.
Yes, sorry for ruining your name. The question is, are there examples of healthy systems or dynamic systems where we can see positive health outcomes? And will understanding these systems better help students and communities understand the systems approach?
Yeah, that's a good question. I think I'm sure there are. So I think it is important for us to identify situations where things are working really well and to try to understand why it is that they're working so well. We don't do enough of that, I think. We are, perhaps because of our connection to medicine and the focus on disease, we're very much focused on looking at adverse outcomes. And we may learn things also from looking at situations in which outcomes are good or better than would be expected under the circumstances, and try to understand, well, why is that? Because maybe by understanding that, how the system generates that, we might be able to work on the places where it's not working right. So I think that's a really important thing to do. Yeah.
Okay. Another question that we have from an email question from Catherine Ellington is, who responds to what kind of research and evidence for action? Leaders and policymakers need report versus public health responses. So in terms of in the development of the materials, where do we send those things to? Is it a dissemination only to policymakers, or is it something where we're in the community, we're in our own sort of public health worlds? What are your thoughts on that?
Well, I'm pretty convinced that if we want to change things, we need to disseminate our work to the public. To people, to common people. And often, so I'm not, of course we need to target policymakers as well, but I think really, we need to work so that the public gets the information out there that indicates that many of these other things that they might not think of as health related at all are actually very important to their health. And I think that's, it's a common misperception that health is driven primarily by medical care or by genes. And the media reinforces those ideas to a certain extent. I'm not saying those things aren't important, they are important, but I think there's a whole other enormous range of things which affect health in very profound ways that often people aren't aware of. And so just getting that message out so that people understand the connections between social policy and health, between education policy and health, is really the most fundamental way to create the climate that would generate the kinds of policies and the kinds of changes in the way our system works that would really eliminate health disparities and improve health for everybody.
We have another email question. It's from Sherry Ann George Smith, who's at our partner conference at St. George's University in Grenada, which we're very excited to have an international partner this year. The question is, given the global shift to population diversity, how do different cultures within a single neighborhood factor into the model of thinking about action-based modeling, giving different cultures or priorities in any sense of the matter?
Yes, I think it is a very important element of how communities and neighborhoods affect health-related processes is through cultural norms and interactions between diverse groups of people. And so I think there has been a number of groups that have that have studied for a while how different aspects related to culture and related to different ethnic groups affect neighborhood conditions and how they interact with neighborhood conditions, and how different neighborhood features are associated with different kinds of ethnic origins of residents and so forth. So I think it's a very important element that needs to be integrated, in addition to looking at the physical environment and the social environment. Also issues related to history and culture of the people who live in these neighborhoods is also a very important element to integrate.
Absolutely. So I wanted to ask a follow-up question that's sort of similar, but one of the things that I was wondering about is you talked in your lecture about the effects of racial residential segregation, and I was wondering, have you seen in your research or in other kind of research that's out there that the effects, for example, of a black person who lives in a predominantly black neighborhood that's racially segregated, would the health effects be the same as if that same person lived in a predominantly white neighborhood that's sort of racially segregated, but the composition of the race is different?
Yeah, that's a very important question. I mean, I think in the United States and also in many other countries, often the race or ethnic composition of neighborhoods becomes linked to disadvantage, right? And so, for example, in this country, many predominantly black neighborhoods also have lack of resources and are disadvantaged in many ways. And so what's really affecting health are those conditions, as opposed to something about the specific composition of the neighborhood. But those things travel together very closely. Of course, there may be other features that are related to the composition of neighborhoods. You know, some characteristics, some social or cultural characteristics of these neighborhoods may be very beneficial for health, and in fact are buffering some of the adverse conditions. So I think one needs to think about both things and really understand, well, what is the racial or ethnic composition really proxying, right? What is it capturing? It's probably not that's affecting health. It's something that travels with it. And so we need to understand what those things are.
And then going back to sort of thinking about training of future public health researchers, and even those who are already currently researchers, how do you see that we might be able to help those individuals better understand culture, better understand history, really understand what a health disparity is and what are the sort of underlying factors that drive health disparity?
Yeah, in training, you mean?
In training.
Yeah, well, I think there are two pieces. You know, first of all, of course, there's, there are ways in which people can read things and learn through scholarship. And there's also a way in which people need to learn through experience, through lived experience. So I think, exposing people to a variety of circumstances, giving the opportunity to experience or at least visit neighborhoods and see what they're like, and so that other element of the lived experience, I think it would be ideal if we could give our trainees both. So the scholarly piece, but also the kind of lived experience. And I think this is also why having diversity among the students and among the faculty is also very important, because having the opportunity to interact and to have discussions in class with people from different backgrounds enriches the experience for everybody. And brings in perspectives that, and this is an incredibly important part of the learning experience and the training of public health people, whether they're going to be researchers, whether they're going to be in the field, whether they're going to be, in health departments, wherever they're going to be. So.
Thank you. Okay, our next question is an email question, and it does come from Celeste Brown, who is the president of the Black Public Health Student Network in Washington, D.C., one of our partner conferences at George Washington University. Okay. Hello, everyone. The question is, how can those who practice the community-oriented primary care model of public health and community-based participatory researchers work together more cooperatively? So how do we break down some of those silos that you talked about a little earlier?
Well, so, I mean, the first thing is, getting people to talk to each other. A lot of times these issues simply have to do with communication and people understanding what they're saying and what they're trying to do. I've experienced that in a very different context, but in terms of just, for example, people who social determinants of health talking to the geneticists and understanding what the geneticists are doing, the geneticists understanding what we're doing. And through that dialogue, one can start to find common avenues that perhaps we hadn't thought of before, and how, in fact, we both benefit from that kind of interaction, and it leads to a more comprehensive and deeper understanding. So I think dialogue is one important way to start that conversation.
We have a phone call. Hello, caller. If you could please give us your name and where you're from and your question.
Hi, my name is Jenny, and I'm from North Carolina. Hi, Dr. Diaz-Rue. I was wondering what the next steps we need to take in this kind of research are, and how current technologies can advance systems research.
Thank you for your question. I think, in terms of, let me take the second part first. Of course, there's been an incredible explosion of all the things that we can do with technology in terms of characterizing the places where people live, characterizing what they do over their day, understanding the different environments that they're in, measuring things about the environment. So we have an enormous opportunity in terms of all the things that can be done. We also have, increasing ability to come up to do these simulated modeling exercises. However, to me, the most important piece really has to do with conceptualization and thinking, and coming up with conceptual models that are dynamic, and that are dynamic but are not, incredibly complicated so that everything is in it, and therefore it's no longer useful. So the big challenge to me is really thinking about ways in which we can come up with conceptualizations that incorporate some of these elements of dynamics, so that then we can actually figure out how important those dynamics are, what implications they have for the things that we're trying to understand.
Absolutely. Thank you so much.
And thank you, Jenny, for your call. All right, Dr. Rue, we've reached the end of our time here, but I do want to thank you on behalf of all of the students and staff who were involved with organizing this year's conference. Thank you for your time of being here. We really enjoyed your presentation and the conversation that we had afterwards.
Thank you. It was my pleasure. Thank you for having me.
Okay. So again, to Dr. Diaz-Rue, on behalf of all of the students and staff who were involved with organizing this year's conference, we would like to thank you for your work and dedication in eliminating health disparities and advancing the cause of health equity for all individuals in society. Often the world of illness prevention and health promotion is wrought with challenges of moving beyond the individual to address environmental and population factors driving poor health among individuals. For those of us interested in public health, your lecture and discussion today provided very tangible steps on how to intervene upon upstream factors related to health, such as the availability of healthy foods or other neighborhood-level health-protecting resources. It was a pleasure having the opportunity to sit here and talk with you today. And again, we would like to thank you for joining us here at the 33rd Annual Minority Health Conference. To our participants, thank you for joining us and for your excellent questions and comments. A special thank you to our George Washington, UIC, UCLA, Meharry, Harvard, and St. George's partners for making this activity a national and now international public health minority student movement. We invite all of you to mark your calendars for the last Friday in February, 1 year from now, when we will broadcast the 15th Annual William T. Small Keynote Lecture from the 34th Annual Minority Health Conference. We hope you will also join us for the Minority Health Project's 18th Annual Summer Public Health Research Video Conference on Minority Health, which will be held June 5th. The topic will be Social Determinants of Health Disparities. For more information on this and other minority health-related events and organizations, please visit www.minority.unc.edu. I'd like to offer a special thank you to the team of students, faculty, and staff who worked tirelessly behind the scenes to make this broadcast a huge success. This is Andre Brown. Thank you again for being here with us today, and we look forward to seeing you in February 2013. Have a